All right, everybody, we're going to get started. Thanks for coming in this morning. So we have 2 lectures this morning, and it's a few minutes after 7, so in the hopes of trying to get out on time, we're going to start with Dr. Myhre teaching us a little bit about the history of internal fixation and lessons learned.
Thank you, everyone. I'm going to get started because I have a lot of slides, so I appreciate you guys being here. I know that this is an aggressive topic for 25 minutes. It would really take a semester course probably to adequately address everything, but we're going to move quickly. You got it, Luke. Can you hear me now? No? Is this any better?
Yes. Yes.
Okay, my alternate titles are above. So especially for the residents in the first 2 rows, this is how we used to fix things, not so good. In other ways, your new idea is actually an old bad idea. So let's get started. So the goals for today are to understand kind of the historical context and the journey of how humans have treated fractures historically, and appreciate just how many of these developments have occurred in the last 100 years of a lifetime. And hopefully this will give you some insight as you see new implants and new ideas be innovated over the course of your careers. Okay? Sadly, no disclosures yet. So the first record of active fracture treatment was discovered by Professor Smith during the first Egyptian expedition in 1903. The University of California sent people up to the Magadir region in Egypt. And they found this both bone forearm fracture that had palm fibers that had been actively stuck into the fracture site. So they believed it was an open fracture. Sadly, the first patient to be treated for a fracture passed away. There was no record, or there was no evidence of it healing. The first written record of splinting was by al-Zahrawi, an Arab surgeon. And I really love this quote because it shows that, we're basically doing the same thing in the pediatric emergency department that they were doing, in 936 AD, putting splints on while there's a bunch of swelling and not really wrapping it tight until the swelling has abated. So if any of the current interns feel like throwing this quote in any of your console notes, like that. Now, history is very Western-centric. Eaton was a British diplomat at Bosworth, Turkey, and in 1798 he wrote back to England describing a method of plaster of Paris that he observed and recommended to English surgeons. So this is a diagram of what he observed. He noted they would leave objects in when they poured in these splints to allow for holes that would hopefully allow for some swelling. And then once the patient's swelling had decreased, they would use the hole in the plaster to pour more plaster that would go in around the skin and fill in the area that decreased. Was pretty clever. Now, Sultan was a Belgian surgeon. He was the personal doctor of King Leopold I. He invented starch bandages. He was also the first person to use chloroform as an anesthetic and greatly improved hygiene and saved a lot of lives of women in childbirth. He was actually one of the early adopters of this idea that early mobilization is good for patients in the setting of fractures. He coined this term deambulation and felt that joints needed to move, which is kind of a precursor to a lot of the AO principles that we use today. I love these quotes. He said, complete immobility of the body, whilst being recommended by authors, is a last resort, which one would be better to avoid than prescribe. Early mobilization causes neither accident nor displacement of fragments, and permitting the patient to distract himself and take himself out into the fresh air instead of remaining nailed to his bed. It has the happiest influence on formation and consolidation of callus. Lucas Championnaire was a French surgeon. He brought the antiseptic tactics of Joseph Lister back to France, and he was attacked in the Society of Surgery for going against forced immobilization. It was called an ankylophobe, and remained alone in protesting these practices. But he said that absolute immobilization is not a favorable condition for bony repair. So we see this gradual shift in splinting and complete immobilization to functional bracing and the occasional use of traction to treat fractures. So I'm sure you're thinking, what about surgery? So, Cam, what do you think the first surgery regularly performed for fracture care was?
Femur repair.
It was actually amputation. So pre-16th century, traditionally amputations were performed with hot iron cauterization and boiling pitch. They had no idea how to tie anything off. So chop off the leg, pour a bunch of hot stuff on the stump and hope the patient survived. And Rothberg is a notable figure in orthopedic trauma history, as he's the first person to have sustained an open tibia fracture and not lost his limb. He was riding a horse that bucked him and kicked his leg and had a bad open injury. Now, the standard at the time was to amputate the leg, which, as we will discuss, had a high mortality rate, but he refused the standard of care and was able to use soap suppositories and prayer to keep his wound clean. He was able to heal his fracture, and he actually was reported as having returned to normal working gait. He is actually ironically famous for advancing the technique of amputation, which he himself refused, and he developed his crow's beak to pull on the ends of vessels and help in their ligation. Dr. Bill Roth has one of the first series on open fractures out of Zurich, and you can see that the years like the late 1800s here, and amputation was deadly. When you meet a patient in the preoperative holding area now, and they have an open tibia fracture, for the most part, you're discussing the risk of non-union, the risk of an infection. Unless it's a very mangled extremity, we have pretty high success rates in treating these injuries. And we like to joke about saving lives in orthopedics because we don't. But in a way, actually, fracture care does save lives. I hope some of this data will convince you of that. In the Franco-Prussian War, 2/3 of people died if they had an open fracture of their lower extremity. In the American Civil War, 1/3 of people died if they had an amputation. And with an above-knee amputation, it was about 50%. And that's 30,000 amputations in the war. So I hope that gives you a sense of just how drastic this was. And even in World War I, which was in 1916, in the first part of the war, there was an 80% mortality rate from gunshot wounds to the femur. This actually improved by the end of the war when they were better at placing patients in traction and getting them out of care. So, 17 slides, but internal fixation. So A.M. Eckhart claims to have seen the first technique in the early 1770s, and there was actually a debate in France going on at the time about the first actual case. Bereng-Fouad cites an example of an open tibia fracture that he saw Dr. Long splint, got multiple drainages for an infection, but the patient refused an amputation. So the story goes, they exposed the bone edges, freshened them up, and then held the bones together with 3 lead cerclage wires. The patient survived. They took the wires out a couple weeks later, and the patient left the hospital after 105 days. And even was described as having gone back to work 6 months later. There's these stories that people tell about these old tabibs in the Arab countries that would freshen up fracture sites with a sharp instrument and hold them together with wires before for non-union. So it's unclear as to when this became commonplace, but this has been going on for a while. Screws weren't really even ever used in the setting of a fracture till the late or in the mid-1800s. The French surgeons here were the first people that reported use of screws. So the first was actually in a depressed sternal fracture. They placed a screw and used it to grab and pull the sternum back out of the chest cavity. And then the second use was in an olecranon. They put 2 screws in the 2 fragments, and then they took wires around the screw heads and circulated the wires together, or the screw heads together, to kind of try to compress the fracture. So plates. So this is the first plate that was ever used, and would stick out of the skin. And was meant to be taken out after 4 to 8 weeks. The first series out of Hamburg was 15 fractures and 4 non-unions. Very different from what we use today. Now, Alvin Lambot is generally regarded as the father of internal fixation, and a lot of the ideas and techniques that he used are precursors to what we use today. He was the son of a professor of anatomy at the University of Brussels, and he was taught by his young brother, who was also a young surgeon. He is kind of famous for having manufactured his own early instruments and implants. He made plates and screws and even made an external fixer, which is very similar to the ones we use today. He published a very classic book in 1913 on the surgical treatment of fractures. And he's interesting because he was really famous for his technical expertise. He made 182 violins during his lifetime, and this was just his side hobby. There's a famous story where he was walking through Paris and was struck by this idea for a new forceps to hold bone. So he runs to a factory and he's trying to describe the forceps to them, and they try to make it and they can't make it. So he like brushes them aside, he rolls up his sleeves, and he is like banging on the metal and fashions it in a forge right there. He fashions the forceps. And the iron workers had never seen anyone so skilled, and they told him, they said, "We're so impressed with you." And Lambot later wrote that that was the highest prize he's ever received, and it moved him more than any of his academic titles. Ironically, actually, the Mayo brothers from Antwerp traveled to Antwerp from Rochester and learned from Lambot. So kind of the clashing of the worlds. William Blaine was around the same time. He was the assistant to Clement Lucas in London, and so his job was essentially to just see all these surgeons' fracture follow-ups. And he was very unhappy with the outcomes. He noticed that a lot of the workers on the trying to carry 200 pounds onto a ship, etc., they were not getting back to their work, and the surgeons were focused on aesthetic results, but they were kind of ignoring the functional limitations that the patients had. And so Blaine was one of the first surgeons to explicitly try to improve functional outcomes with surgery. And he wanted to operate on all these different fractures, but Clement Lucas wouldn't let him. So he had to wait until Clement Lucas developed a terrible case of typhoid and was out of the out of his clinic for 6 months. And then he got his first series of fractures. And so in a way, I like to think of him as kind of an old-timey Justin Howard, the first fractures, and say, hey, I can make everyone better. Really interesting. So William Lane is the first patient to ever have a patient that was that had observed primary bone healing, because one of the patients died distant to the fracture, and they took down his fracture site, and they looked and they saw that his plate and screws were in place and that the bone had healed without any evidence of callus. So that's the first kind of clue that there's a different way for bone to heal. Just to touch briefly on intramedullary fixation, I mean, even hundreds of years ago, there were records of the Aztecs that would use, they would take non-unions, they would freshen up the bone, and they would use resin wood in the intramedullary canal to help set non-unions. Berkshire is the first to have used ivory intramedullary pegs. Haugland used beef and human bone pegs, mostly for femoral neck fractures. And then Koenig was the first to describe that dual approach for femoral neck fracture. So he made an approach right over the front of the hip capsule. He would put his finger and he would feel the fracture. He would do the same technique we use today, traction and internal rotation. And then he would make a separate incision over the side of the hip and he would shove a peg up the femoral neck blind. This is all before radiography became common. Now, Ernest Groves was ahead of his time. He was in England. He was actually using metal flanged nails to try to treat femurs and tibias, but his technique wasn't as scrupulous as William Blaine's, who was kind of known for being really technical, really clean, etc. And so he actually had so many infections that he was known as Septic Ernie, which is hilarious. And so William Blaine actually wouldn't touch anything in the wound. He would not. He thought that all gloves were contaminated. So anything that touched the fracture or touched the wound had to have been sterilized and then placed in the wound. And the drapes were unsterile. I mean, maybe I should have compared him to Dr. Chris Pell instead of Dr. Desmond Allen. So Kushner is kind of the OG nailer. He worked very closely with an engineer, Ernst Pohl, and a Professor Fisher, who probably deserve just as much credit as him because they helped him design all of his implants. His first nail was actually V-shaped, not the kind of typical clover shape that we think of today. So even though things had been treated with intramedullary fixation, he pioneered a lot of things, these large, stiff implants that enabled people to actually weight bear. And then he moved from the V to the clover because he used guide wires. And the nail would not stay on the guide wire as you inserted it. It would fall off. But the clover only had that one little opening, so it would slide over the guide wire. his innovations really propelled us into modern nailing. He used full-length nails. He actually hated disrupting the periosteum. He did not believe in placing screws. And a lot of his techniques of getting patients in and out of the hospital quickly was due to the limited penicillin nurses and hospital beds from World War II. He also designed a signal arm for trochanteric fractures, which was kind of the first time that was described. He designed flexible cannulated reamers, or like we still use today, and he was the first to compress a fracture over a nail. Shout out to the modern day Kushner, David Rothberg. I mean, the current generation of surgeons kind of continues to push the boundaries with instrumental fixation. So Robert Denise, he's kind of the early start of the AO group. So he graduated from the University of Brussels in 1904 and was a general surgeon, but he was influenced by a lot of the people we've talked about, Sherman, Lambot, Blaine, and their concepts of stable fixation permitting functional rehabilitation. So he wrote the book on osteosynthesis, and his objectives in this French book, so immediate active mobilization, complete restoration of the bone to its original form, and then this primary healing. And so these are essentially the AO principles, except that now we've updated to kind of include this preservation of blood supply, and we don't hate callus as much as kind of the early swing towards surgery and plating was to kind of try to get rid of callus. So Maurice Mueller met Denise, and he was very inspired by this book, and so he got these surgeons together in the 1950s and kind of formed this study group, which was, I would only let Dan Knight pronounce this because I will mess it up, but it was the original AO. And they kind of had this meeting of the minds, and they collaborated with Swiss metallurgists and engineers and devised a system of implants, and set up a center in Bern, a lab in Davos, Switzerland. And the modern implant company, Synthes, came from the collaboration with Stroman, Metallurgic Research Institute. So Synthes is actually from the AO. It's, the modern day equivalent. So I'd like to just kind of briefly touch on the University of Utah. How do we treat fractures here, which is kind of inspired by Dr. Dunn, since he's been here for a while. So how did we treat fractures in the 70s and 80s? So in tibias, even in the 70s and 80s, a lot of these were being treated in casts and sometimes plaster with pins, which you would manipulate the fracture fragments with pins and then wrap the whole thing in plaster, and then you could take it off once the callus is set up. There's a ton of different external fixators. We use the Roger Anderson frame here, and you can see that there's a ton of different systems, but most of them had kind of similar ideas. And we were using Kushner nails here at the University of Utah. A lot of times, we would open up the fracture. You would pass the nail retrograde up through the hip. You would knock it out the piriform fossa, make an incision over the hip, pull it all the way out. Then you would reduce the fracture, hold the fractures together, and reinsert it. Now, the big debate at the time was whether or not we should be reaming, and how did that affect the blood supply. And so a lot of these weren't reamed, and a lot of the Kushner nails, the Kushner nail, it functioned by being compressed because it had that clover leaf. And then once it was inserted and had diaphyseal fit, the push out would kind of give you the stability. And so it was easy for nails to become bound up. So Dr. Dunn told me a story that he was called by a resident at the VA, and they had a nail bind up and couldn't get it in or out. And they had been wailing on it for 3 hours before they called Dr. Dunn. And so what did they do? So they closed up the wound. They attached 30 pounds of traction to the Kushner nail. They sent the patient to the floor, and they left him there for a couple of days. And 2 days later, they hear a giant clatter on the floor, and the nail has come loose and pulled out. So I thought that was an amazing story. Similar to some of the VA stuff today. There was a nurse at the University of Utah who was in charge of balance traction and using the traction devices, and Dr. Gunn said, yeah, this guy said, the residents have no idea what they're doing. So I guess not too much has changed. You can see the Thornton side plate with the Smith Peat nail, which went up and was used for kind of trochanteric and femoral neck fractures, kind of similar to some of the femoral neck systems of the DHS that we use today. And then here's a very interesting timeline. It wasn't until the 1960s that we had power instruments. No one had operated on a pelvis until the 80s when Winquist in Seattle had access to a CT scanner and started to operate on the pelvis more. And then, Letournel's first publication was 1974, which is crazy to think how far we've come just in the last several decades. Interestingly, So North America was an early adopter of acetabular surgery, and a lot of Europe was kind of spurned Letronel originally. And so a lot of North American surgeons were traveling to France and going to his yearly course. And we didn't even have C-arms here until the 90s. So the distant history of surgery is pretty well established, but now there's been this explosion of orthopedic surgery profits, implant companies, et cetera, and there's a lot of good and bad ideas floating around. And so I think it surprises probably no one in this room, but there's very little in the official way of records about implants or designs that haven't worked or been withdrawn. So I think just very quickly, I want to kind of touch on a couple that I found interesting. Now, the FDA does have a record of medical device recalls, but there's thousands and thousands a year in here. If anything is packaged incorrectly, if anything breaks, it's in the database. So it's very hard to sift through that and actually find like what big concepts kind of didn't work well. So the Edgar's plate, he was a famous surgeon in America in Texas. I love this introduction on the Edgar's plate that he wrote. He said, the internal fixation of fractures has a definite but limited field of application in the treatment of fragment displacement. The closed method of treatment of fractures has been accepted as the most desirable. There might be some people that would debate that, but he came up with this plate that was essentially supposed to allow sliding and compression. So it had slots in the plate, and then the screws would be tightened all the way down. And he thought that this would allow the muscle tone to help the fracture heal. These are images kind of from his original publication. Now, actually, Lambot described a similar slotted plate in 1907, but he abandoned it. The Edgar's plate was out for a while, but talking with Dr. Dunn, a lot of times those screws would bind up. There wasn't a locking mechanism that allowed for smooth axial compression, and so the plate would often break and the screws would bind and didn't really work that well. You know, early locking fixation, there were a lot of different ideas. I know that Joel, you recognize this idea? Yeah. So, you know, the first idea for locking fixation was this Shuli bolt that would slide onto the other side of the screw and then hopefully provide some axial stability before we had the true locking screw technology. And that's obviously gone out of favor. So the discotheque nail, so this was, you know, not that long ago, but it was marked as it was a self-locking nail that would expand and used a pump system to inflate it. And it reduced the amount that you had to ream, it reduced surgical time, it was an amazing idea. So why aren't we all using it? You know, the first publications were positive, but that means the publications started to come out that were not so positive. And I think it's a little ironic that some of the, you know, initially a lot of these positive publications are in pretty well-respected journals, and if you want to look at like find pictures of broken nails and failures, sometimes it's not, you know, published in JBJS. So the Brooker Wills nail by Zimmer. So this had deployable fins. I mean, these all seem like really cool ideas. This was hopefully to avoid interlocking screws but still provide rotational stability. So, you know, the results here are excellent. The first result on PubMed for the Brooker Wills nail is JBJS, and it's a modified Kushner nail. It allows early mobilization, no issues with removal or breakage. 4 years later, you know, significant problems, difficulty with insertion and removal, the fins broke, the nail bent, has more mechanical failures. So the Bosworth or Rockwood screw, you know, a screw from the distal clavicle that will go straight into the coracoid, which sounds actually like a great idea if you haven't heard of this before. And all of the initial publications were positive. And then, you know, we start to hear that there's pull-out and there's cut-through and it doesn't actually work as well as you'd think. Loosened, it eroded. Now, I want to thank Dan Knight for providing me with this image because the Synthes flexible humeral nail has been scrubbed from the internet. You can look up the item number, you can look up the name. There's nothing on the internet that ever would suggest that this existed, but this existed. And it's incredibly interesting because it got pulled from the market and no one uses it. Ironically, it looks very similar to a current product being peddled today for pelvis fixation. This looks like the exact same technology. It's these tensioning wires that allow you to insert something flexible and then hopefully it locks up. Now, maybe Curvifix will be a huge success, but you know, sometimes, you know, there's quotes about, you know, history. So, and then finally, I thought that the Synthes dynamic locking screw was actually an excellent idea. So, when locking fixation first came out in the early 2000s, people would lock everything, and it was stiffer is better. And then plates broke, things cut out, fractures didn't heal. So Synthes came up with this locking screw that was supposed to allow more motion, but still provide axial and angular stability. Now, so it used this pin inside, right? And so the threads proximally near the head are not connected to the rest of the screw. So it would allow some motion, which is an awesome idea. Unfortunately, they tended to break and they were really difficult to take out. And so they actually got pulled from the market. So I think that, this is a very, very short overview of some issues with internal fixation and some of kind of where we've come from. But I think some of the lessons I've learned is that, hardware is going to, if it breaks frequently, it's not going to be a great idea. If you're going to put it in, you got to think about taking it out. So many good ideas actually are ruined by the removal of the hardware. And then really, I kind of thought I would come in and have all of these ideas that were clearly terrible and, it would be very black and white, but it's not black and white. It's really, when it comes to, I think, fractures, and this is maybe a little bit different than the metal on metal hips or joint replacements. With these implants, it's really about how you're using it and what you're depending on it for. And so I think you just have to be thoughtful when you're using new ideas and exploring innovation. Much of innovation was born from desperation or going against the standard of care. So I think it's interesting to think about, the people that first didn't want their leg cut off for an open fracture, or the first people to use nailing. Those things were totally going against the grain, and there were people in surgical society meetings that would stand up and yell at those people. But now the entire field is different, and so I think that's a really interesting kind of lesson for everyone, who's a young surgeon here to kind of take going forward. Now, for bad ideas, the initial reports will often be positive, and failures will rarely be published or reported. But I think there's this delicate balance between being able to go against the grain and innovate, and also listening to failures and being studious and not being too early of an adopter. So I'd just like to thank everyone in the room, but especially Dr. Duns, Dr. Stevens, Dr. Sultan, Dr. Higgins, Dr. Beals, Dr. Marchand, all, and Dan Knight especially provided so much insight and so there's a ton more failures in orthopedics, and I think failures are way more interesting than successes a lot of the time. And so I wasn't able to touch on everything, but thank you for your time.